PTC to provide an introduction. Over to you, Derek. And Derek, it looks like you're muted.
Thank you for this opportunity for us to be here with you today. My name is Derek Newby. I'm a TTA specialist with the Prevention Technology and Transfer Center for Region 6, and New Mexico is one of our states within our region. So we're happy to be invited here today to assist. The views and perspectives of the speaker that we have for you today are those of that speaker and do not necessarily represent those of HRSA or the Health and Human Services or SAMHSA. The speaker we have today for you is Dr. Iris Smith, and she's an associate professor at Emory University, Rollins School of Public Health, where she has taught graduate courses in program evaluation, substance abuse, social determinants of health, and mental health. In addition to teaching, Dr. Smith has served as the coordinator for the Center for the Application of Prevention Technologies, Southeast Resources team. In this role, she supervised a team of training and technical assistance specialists, content experts, and consultants who provide training and technical assistance to substance abuse and mental health services state grantees. It is my honor to give you Dr. Smith so she can share her expertise with you today on the rural.
Well, hello. Well, thank you for the introduction. Hello, everyone. I'm looking forward to today. I'm going to go ahead and share my screen. I'm looking forward to hearing from you, and we actually have some time in here for interaction, so I can hear some of your thoughts. So I'm going to pull up my screen. Okay. Okay. Can everyone see the PowerPoint slide now?
Yes.
Okay. Cool. All right. There's an acknowledgement that I'll go through with you, which you've probably seen before, and you can read it. But the presentation was prepared by the South-Southwest Prevention Technology Transfer Center Network under a cooperative agreement with Substance Abuse and Mental Health Services Administration. And then it gives you some information in terms of copying. And the opinions expressed herein are the view of the PTC network and do not reflect the official position of the Department of Health and Human Services at SAMHSA. No official support or endorsement of DHHS, SAMHSA for opinions described in this document is intended or inferred. And then you see the grants which have funded it. So that's me. A couple of years ago, I look different now, but that's what I used to look like. Why don't we start by posting some things in the chat? I'd like to hear from you some words that best describe living or working in a rural community, just to get a sense from you what your experience has been and what your thoughts are. I see awesome. I see family connection, limited connection. Good. Okay. Lack of resources. Okay. So there's both some positive and some negative things. Isolated, no noisy city. I can identify with that. I'll talk a little bit about my experience here in Florida. That's all good. Personalized relationships, absolutely. Okay. Extended family connections, diverse. That's a good one because we don't often think about rural communities as being diverse. Culture, good. Okay. So you've got a lot of positives and negatives there. Some are closely knitted is another one that's come up. So some of those characteristics will definitely support your work. Others will challenge it. Traditions, good. Okay. Well, let's talk. I'm going to talk a little bit in general about rural communities. Let me take a look at the learning objectives. I'm going to talk about the importance of addressing health disparities, which I'm sure you all are aware of. And then identify some risk factors for health disparities in the rural context, particularly as they relate to substance abuse. And then we'll talk about strategies for addressing some of those unique challenges to prevention in rural settings. And I can give you some examples from groups that I've worked with that may be helpful to you. I want to start by giving you a definition for rural. Everybody has a conception of what rural means, and many of us see the red barn there. And certainly before I had a lot of experience working with rural communities, that's what I thought of. Basically an isolated agricultural community, sparsely populated. Just some little facts on rural America. 97% of the land mass in the U.S. is rural. So a lot of the United States is rural, even though the population is concentrated more on the coast than in the city. And that's certainly one thing I experienced here in Florida. I had no idea that Florida was mostly rural. That was an aha moment for me. Despite the fact that 97% of the land mass is rural, only about 19% actually live in rural areas. And the other misconception I think sometimes people have is that they think of rural communities as being poor, isolated, without resources. But the fact of the matter is we have some very wealthy counties that are considered rural, particularly when you go into the West and you have some of the large ranchers who have in Montana and that area. They're quite wealthy and they do have resources there. And it's a totally different experience from dealing in rural Alabama or some of our other rural states. So that's something that's important to keep in mind. For the purposes of this particular presentation, I'm going to use the U.S. Census Bureau's definition of rural, and it's very broad. So it's anything that's not urban. So that includes small communities that may lie outside of an urban area, as well as frontier kinds of areas where it's sparsely populated. And I know in New Mexico you have probably all three, if I'm not mistaken. So rural communities vary widely, which is what I've seen. So it's not if you've seen one, you've seen them all. And they differ in location and demographics. So if you look at this, this particular slide, which is specific to New Mexico, you can see that when we think of rural areas as being homogeneous and poor and isolated, we usually think of them being primarily white, but in fact, the demographics are evolving. Like much of what we're seeing across the country, COVID has certainly had an impact on that. And we have to keep in mind that there are minorities and people of color in most of these communities, and that number of people is growing for a number of different reasons. So if you look at some shifts in terms of the demographics of New Mexico, you can see the blue areas are showing a decrease, and then as you get to the yellow and the gold, you're showing areas where there's been an increase in terms of change. And from what I've seen in terms of the demographics of New Mexico, you're looking at somewhat of an increase around Latino and Hispanic populations. And again, if you look at the yellow and gold, you'll see where there's been an increase of more than 3% in terms of the population change. So again, this is evolving. And what that means is that you need perhaps to think about things a little bit differently, and you'll be dealing perhaps with risk factors and situations that are different. So we want to talk about health disparities specific to substance abuse, but I'm going to talk also about general health conditions in rural communities. And you can, as I'm talking, you can think about how this applies to New Mexico and the communities you've worked with. And I want to give you a definition for rural health disparity so that we know what we're talking about. A disparity is a difference in a health condition that's based on cultural or socioeconomic differences. So things like race, age, socioeconomic status, gender. Okay, health disparities exist because of some of the differences along those demographic categories. What we aim for when we do prevention or we do any kind of intervention in the community for health, we're looking for health equity. And that's a goal. It's very hard to reach, and we haven't reached it in very many communities, but that's where we want to go. That's the end of the road. And health equity simply means that it's the highest level of health for everyone in that community. So we want to make the community as healthy as it can possibly be, which is a lofty goal. The way that we do that is by identifying and addressing health inequities, which is that third bullet. When we think of health disparities, it's not only unfair, but sometimes reflects injustice. So to address these health inequities, communities have to remove obstacles to good health, and you have to be able to identify them. And there may be such things as poverty, as discrimination, implicit bias on the part of providers or others in the community, and the consequences of those. And when you're in a community that's affected by these kind of health inequities, there is also likely to be an increased amount of stress, and substance abuse, of course, is one way that people will cope with that kind of stress. But you're also talking about low-paying jobs, education, housing, safety, as well as health care. So if we look generally at the rural context in terms of the prevalence of substance abuse and the type of substance abuse you see, it's not that different from the country as a whole. You do see an increased risk of substance use disorders for many of the reasons that I just mentioned, as well as risky alcohol-related behavior. You have a tendency to see a bit more binge drinking, and tobacco use is typically higher in rural communities as well. And again, just like we're seeing generally across the country, there's been an increase in the use of illicit drugs such as opioids, heroin, prescription medications, and methamphetamines are also drugs that are frequently abused in rural contexts. And although urban areas have higher overall rates of illicit drug use across all age groups, rural participants experience more consequences from the illicit drug use. So even though the prevalence may be very similar to what you see in a city, the consequence of those behaviors may be much greater for people who live in a rural area. The other thing that you see as you look across a number of rural states, rural communities in the US, is that the choice of illicit drugs may vary. And a lot of that depends on availability as well as factors related to access. For example, historically, we have seen higher levels of drugs like methamphetamine in rural areas than we have seen in some of the urban areas. We're also seeing a high risk of semi-synthetic opioid drugs compared to urban residents. And a number of factors here are converging. And again, you've probably seen this in your own experience. I mentioned that the consequences of using drugs is greater for those in rural communities, mainly because treatment facilities, service providers are more scarce in a lot of these communities. There tends to be a higher rate of unintentional injuries, for example, in rural areas. And there's some indication that some of the drug use is tied to self-medicating for people who don't have access to healthcare or a primary healthcare provider. And those things make the drug use problem in rural communities a little bit different. The other thing, of course, is that because of the lower density of population, people have to travel to get to service. And so having a car, because there's often not public transportation, so if you don't have a car, it's very difficult for you to access some of those services. With regard to tobacco, rural populations have consistently had a higher rate of disease prevalence related to smoking compared to urban communities. And again, for many of the same reasons, lack of services, some of the stress that's associated with life in a rural community, which leads to higher smoking rates as well. We also see a higher risk of behavioral health disorders in the rural context, and there's some listed here on this slide. Depression, rates of suicide. And what I also want to say in regard to this is that as you look at the diversity within these rural communities, what you'll find is that there are pockets or subpopulations where the risk of some of these things is much higher than in others. And so when you're working in a rural context, it's very important that you get to know the community well, and that you can work with the community to identify where those hotspots are and which populations are at highest risk. For suicide, for example, we know that Indigenous groups, Native Americans, are at higher risk for suicide. The levels of suicide are much higher. And the reasons for that may be different and related to things that are more specific to American Indian or Indigenous culture. So understanding those things is very important if you're really going to make a difference in terms of outcome. There is also something called, that some researchers have referred to, called the Southern Rural Health and Mortality Penalty. And that is, if you look across the country and you look at rates of various types of behavioral and health disorder, other health disorders, what you see is that the southern tier of states typically has a much higher rate of things like even cardiovascular disease and other types of mortality and chronic disease, as well as substance abuse. Part of that is related to economic kinds of factors in the South, more poverty, lack of resources, all of those things. It's also related to history and the fact that the South has evolved from what was a very segregated, people refer to it as a Jim Crow kind of a culture. And the results of, there's some residual effects of that, I would say. And racism, of course, is something that we do have to address from time to time when we look at disparate rates of some of these things. There are also a number of subpopulations, such as listed here on the slide: women, low-income children, veterans, non-Hispanic, Black. I've mentioned American Indians and also Alaska Natives up in the Pacific. Life expectancy is generally lower in rural counties than in urban counties. I mentioned that the greater opioid use and the increase in opioid-related deaths, and of course the things that ride along with drug use, such as exposure to HIV and hepatitis, are also higher in those areas. In many rural areas, you see a higher rate of injection drug use and resistance to needle exchange programs, usually because of the conservative politics that we see in many rural communities, and the stigma that's attached to drug use in many of these cultures. Some of the things that we don't think about when we think about drug use in rural contexts is how drug use behaviors themselves may change because of the rurality of the context. And a recent systematic review looked at 32 peer-reviewed qualitative studies. We don't do enough qualitative research, I think, which found that the economic strain that you see in rural communities can lead to riskier behavior among the people who are using. And some of the examples of that are that in interviewing some of the respondents in these studies, what they found is that respondents talked about switching from snorting to injecting to reduce the cost of using. And they also engaged in riskier injection practices, such as multiple injections per episode and sharing injections with other users. So if we're looking at harm reduction, we also want to understand how these kinds of factors also impact what we see in terms of outcomes. I mentioned before that there tends to be a higher rate of self-medicating, mainly because the medical services in many of these communities are not accessible. The other thing that this particular review highlighted was that often drug users in rural communities will travel great distances to an urban center in order to obtain drugs. So unlike the urban environment where your drug dealer or your source of drugs is in the community itself, there is a lot of travel between the urban centers and the rural centers. So there's not a clear delineation in terms of what you're looking at in terms of contributing factors. Another thing that was highlighted in this particular review was the fact that drug use is often intergenerational. And when we talk about, some of you mentioned close-knit families and family connections, which can certainly be a positive support for not using drugs, but it can also be the reverse of that. And where there's intergenerational use, the attitudes towards substance use may be more facilitating rather than preventive. So it's important, again, to understand what's happening in the individual communities that you're working with. I'm going to go on and talk a little bit about, I think I've gone through most of this. This is the 4 A's and a C, which will help you kind of think about some of the barriers or factors that are related to substance use and other behavioral disorders in a rural community. The idea of access and getting to the services that do exist when they exist. Accessibility. One of the things that we see if we look across the country at rural communities is that there is an overrepresentation of older people, largely because the younger people in the community have moved away in search of employment. Those that are fortunate enough to be able to further their education generally don't come back to the rural community. So you have people who may not be very mobile, they may not be able to drive anymore. And so, what may look like a reasonable distance to travel may create a greater barrier for some of those populations. And of course, availability. Acceptability has to do with a lot of factors, and I'll talk a little bit more about that. Trust, certainly the stigma that's attached to seeking service, because in a small community, you likely have less anonymity. So people may be reluctant to walk through the door to a drug treatment facility and ask for help for fear of being identified within the community as being a drug user. The culture itself, in terms of some of the interventions that we promote, may not find them to be culturally acceptable. So understanding what those barriers are is important. So these are some of the things that contribute to substance misuse, and I've talked about some of these. Certainly poverty, unemployment, community disorganization, norms within the community. The low academic achievement and the lack of hope and opportunity for the future leads to depression, feelings of isolation. And that kind of desperation and loss of hope is sometimes what drives people, as you well know, toward the use of substances, including those that are legal, alcohol, tobacco, and of course the illicit substances. Low neighborhood attachment. The sense of a neighborhood is not the same in a rural environment as it is in an urban environment. My husband and I grew up in New York City, and for us, our neighborhood, or what we considered to be our neighborhood, was our block. For my husband, who was in Manhattan, it was his building. So there's a different sense of what a neighborhood is in many rural communities. There may be fewer opportunities outside of church, and I'll talk about faith-based institutions as well. So there may be fewer opportunities for positive social involvement. There's not a lot of activities, for example, for adolescents and young people where they can gather in safety to interact with each other without drugs. There is a higher proportion of families living below the poverty level, more unemployment. A greater percentage of people will have public insurance but be uninsured. And they, as I mentioned, they experience a greater sense of stigma. When we look at adolescents, their drug using or alcohol using behaviors are a little bit different. Rural adolescents are more likely to binge. They're more likely to drive under the influence than urban adolescents. They're more likely to have used at the age of 12 or 13, which is somewhat younger than you would see sometimes in rural communities. And I think the last bullet on this particular slide is worth noting, which is that studies that have looked at substance abuse in rural communities, particularly among adolescents, find that even when you account for the risk and protective factors that we would normally highlight in terms of prevention, you still see a disparity. In other words, they don't account for the whole problem. And a lot of that has to do with some of the things that I've been talking about. So risk and protective factors don't always explain the full rural-urban difference. When you look at high-risk populations within the rural setting, it's not different from what you would see in an urban setting. Women are a risk group, and women, particularly pregnant women, are at a particular higher risk. Again, because they don't have access to the same types of services and support services, particularly behavioral health kinds of services in rural communities. Women who are substance abusing may experience a much greater stigma in a rural community. Again, depending on the demographics and the culture of the community, if you're a substance abusing woman and viewed as being what one woman in a study that I was looking at called herself a junkie mom, people view that as a moral failing. And so there's less of a tendency to view it as a disease that's treatable and more of just the fact that this person is immoral and is doing bad things and how could they possibly do this to their children, which of course alienates women from the system. Veterans are, you find more veterans living in rural communities than you do typically in urban communities. And again, the same kinds of issues affect them, such as not having access to services, and I was looking for the statistic. To some extent, they do have lower rates of mental health issues than urban veterans, but they have a lower quality of life and a greater disease burden. So many veterans who are returning from some of the recent activities overseas have come back disabled. So there's a need for more support. There's a greater risk, perhaps, of self-medicating in some of these veterans. The statistic I was looking for, 37% percent 37% of urban veterans are enrolled in the Veterans Administration health system, as opposed to, let me take that back. 58% of rural veterans are enrolled in the Veterans Administration's health system versus 37% in urban veterans. So they're more dependent on the public health system, with less access to private health care providers. I've mentioned the issues with people of color, with indigenous populations, with older adults. Also, there are fewer services that can work with people who have coexisting conditions, whether they're behavioral or otherwise. So again, when you're looking at veterans, when you're looking at older adults, there are fewer services that have the adaptations to address some of the needs of those populations. And yet the need is there. So, and this is kind of a summary of what we've been talking about. When you talk about understanding mental health and substance abuse in a rural context, one of the things that you have to look at, I did it again, I probably should have let somebody else do the slide, is the prevalence of the problems that you're addressing. So looking at mental health issues, identifying where there are hot pockets, where there seems to be a lot of issues around behavioral health and substance abuse is one thing to look at. We also have to look at access, and that is whether or not people can actually get to those services. And when you talk about access, it's not just about physical access, and I mentioned that before, but what is the cultural perception of the services that are being provided? How great is the stigma for substance abusers or others suffering from behavioral health disorders to really get to those services? Are they affordable? You have more uninsured people, so that is also an issue. Are the services themselves acceptable in terms of the culture and demographics of the community that you're working with? If you're working with, for example, a population that has a lot of Hispanics who speak primarily Spanish, they may speak English, but not well. They may have some reservations about going to a provider who doesn't have someone on staff who can talk to them in their own language. So the availability of those kinds of services are important. And accessibility, I mentioned, just in terms of getting to the place, getting into it, for the disabled population, for the older population, and so forth. And also the time that services are offered, because you have a lot of people who are working in a blue collar or non-professional environment where they can't get time off to go to the doctor or to go see a psychologist. They're penalized for taking time off. So you have to take that into consideration as well. Access also is about geography, the distance between services, the distance between providers. I've mentioned the cultural kinds of barriers. The other two squares here refer to things that are going to differ across rural communities, and it would be important for you as a prevention specialist to really have a sense of where the highest risk populations are and how the socioeconomic factors within that community have affected access to services within the community. When we talk about policy, sometimes that seems like people get very apprehensive, because if you're a prevention provider and you have one or two other colleagues who work with you and a community, that seems like a big task to take on. But there are examples where policy changes can occur, and they can occur either outside of outside of a community or within an organization. And I've worked with both. when I worked in Georgia, I worked with something called Family Connection. I actually saw that come up in our little chat earlier. Was actually the name of an initiative that was being implemented in the state of Georgia. It's probably 20, 30 years ago now. I don't know if it's still ongoing. But what it involved was really looking at rural communities largely. Although there was at least one Family Connection in every county in Georgia. But in the rural communities where you had few service providers, what the Family Connection did with the state support was allow for blending of funding streams, suspension of regulations that prevented people from working together, things such as data sharing, for example. Also sharing staff resources. For example, having a mental health or substance abuse counselor available to go into the school system. And I'm thinking of one very small community in Adel, Georgia, which there was one school system in the community, one hospital, and a very small set of providers. But what they were able to do was break down those traditional organizational barriers so that they could share their resources. The other thing about Family Connection, which I always thought was very intriguing and positive, was that the community came together and decided what the problem was. And that gets back to community engagement, which is something, if you're familiar with the SPIF, you know that community engagement is critical to working through the SPIF for prevention. But what that did, once a year, they'd all come together and they decide, this year we're going to focus on substance abuse. This year we'll focus on low birth weight babies, or teenage pregnancy, or high school dropout. And then they they would plan how they would blend their resources to be able to address what they viewed as the most pressing problem within the community. So that's an example of a system change that is occurring is occurring inside an organization or a community. Another example from my own experience of system change that occurred inside a system was when I worked with the American Cancer Society, and they funded a national urban school leadership institute for school systems across the country. And they had 7 school systems. One was in New Mexico, as a matter of fact. And what they did was work with the school system, starting with the superintendent all the way down to representatives from the teachers, administrators, community folks, the health department within the community. And they worked with all of those different groups to affect change within the system. And again, by bringing resources in some cases, or just changing some of the traditional kinds of organizational connections and regulations that prevented people from working together. And it was a pretty effective kind of an intervention. So environmental change strategies, which is another kind of a big change strategy that goes beyond what an individual can do, involves changing the economic, social, or physical surroundings that surround the outcome. So they might address population health by fostering more walkable areas, or places where people can, or students, for example, can engage in athletics, have additional activities other than just cruising and boozing, which is what happens in a lot of these communities. So increasing parks, greenways, trails, that kind of thing. That's a major environmental change. So here you're changing the structure of the place, which is important. It leads to changes at a number of different levels. There are more examples. One is another one, which is an in-school intervention, is the Kentucky Home Place Project, which addressed health by bringing health providers into the school to provide health information, screening, and coaching to both the teachers and to the students. In Ohio, school as a hub for health is very similar, with the goal of improving physical, mental, and social health by bringing others into the school system. So you're changing the way that community organizations work together and breaking down some of the walls of the silos that will often exist. And it's not just in rural communities. A lot of these strategies have also been implemented in urban communities. My experience has been, though, that the ones that are in the rural areas tend to work best because of the closeness of the community as a whole, and that people are familiar with each other as individuals and more familiar with the organization. So at the individual level, when we talk about community intervention, you're talking about increasing access to services and increasing acceptability. And a lot of that has to do with health promotion strategies, which I'm sure a lot of you do. There are also family level interventions where you work with parents, educate them, and provide them tools and resources and support to reduce the risky behaviors that you might be seeing in the adolescents. At the organizational or institutional level, you can embed additional services within an organization. So the change is occurring within an organization, but it's, again, about breaking down silos and making it easier for sharing of information and services. And of course, there are a lot of issues you have to work through when you take that route, things like confidentiality, sharing of information. And so it's not something that you can do necessarily in a short period of time, but it is something that is very effective, and it can happen over time. Again, I've given you a couple of examples of those. And at the community level, I mentioned the fact that you can change the structure and work with community leaders to reduce some of the stigma, get them involved, and empower them to be able to help you in what you do. Also at the policy level, I think one of the largest barriers to implementing these kind of community level interventions is usually funding, which is why I found the Family Connection in Georgia to be such an intriguing way to look at it, because the state allowed these organizations to blend funding streams and looking at providing services in different ways, going into the schools, for example. Those kinds of things had a tremendous impact in terms of the outcomes. And the Family Connection actually was evaluated, had a very comprehensive evaluation over a number of years. I was involved in some of that, and the outcomes were very positive. And many of the coalitions that formed continued years after the funding has ceased. So when you build those kinds of community organizations, you're also helping to promote sustainability for the future. We go to 1:30, right? Or just 1 o'clock? Okay.
1:20.
1:20, okay. So I talked about community engagement. So these are some of the organizations that you can engage with when you're implementing these types of programs within a community. And again, it's not just in rural communities, but also in urban environments as well. Collaborative care actually originated in the medical system or in the health system with regard to medical issues, the chronic care model, which looks at reforming and adjusting community-based resources to support working with a particular health outcome. And most of the research has been positive. When you look at these community level interventions, they have worked. But what's important is that you engage the whole community and that you identify who those people are. I'll move along and maybe give you some more examples a bit later. There is a handout that you might find useful. There are some toolkits. And the one thing I would say to all of you as well is that you don't have to look just at substance abuse prevention. Some of the examples I've given you of successful kinds of community level interventions really didn't start with behavioral health issues, but may have started with what the community viewed as being the more pressing issue. But once the door was opened, they began to address other things as well. So if you're looking for examples of promising approaches, you can also look at some of these other interventions, which are looking at different types of health issues. You want to look at what the problem is in the community you're working with. What is the drug? What is the pressing issue with regard to substance abuse? Is it overdoses? Is it adolescent alcohol use? Is it binge drinking among young people? Whatever it is. And understanding, as I said before, where those hot pockets are. Do you have some really high-risk populations within the community that you may need to focus on? This is a framework from the National Institute of Minority Health and Health Disparities. It's a research framework, but as you look at it, you can see it basically gives you examples of what you can do at each level. It also highlights to the left the different factors that will influence what you're looking at as you move across the continuum from individual to societal. So clearly there's some biological issues. When we talk about substance abuse, we know that substance abuse typically runs in families, and all of the research on alcohol has been going on for many decades. We're only beginning to learn more about synthetic opioids and some of the intergenerational effects that may occur. If you look at the built environment, you know, what's going on within that individual's environment, within the household, within the school, the places that they frequent, what are the community resources? And all of this may sound familiar to you because if you're familiar with the SPIF, you know that these are some of the things that you look at when you're doing a needs assessment, when you're wanting to build capacity. You want to look at what are the strengths in the community and where are the gaps. The sociocultural environment I mentioned in terms of language, for example, cultural identity or perceptions of substance use or treatment services for substance use. Who are the social networks? What are the norms in the community? Again, I think it's all pretty much self-explanatory as you look across. And of course, we don't, as prevention specialists, don't usually get to changing society. But ultimately, as you move from left to right, that's the goal. I mean, that's where we want to go. And it's one step at a time. When I was in graduate school, one of my professors had us read an article. It was by an author named Wyke, and I don't have the citation. But one of the things that has stayed with me, and that was a lot of years ago, like 40, was that social change is based on small wins. It's based on individual steps and individual efforts. And even though as a prevention specialist, you may not have the capacity and the capability of doing some of these higher level kinds of interventions, you can take a small step in that direction. And it's the building of these small steps over time that leads to the outcomes at the societal level that you see on the slide. So that's just something to keep in mind. So where does this take you and where should you go with all of this? First of all, you know, what I've been saying is do your homework. Get to know what your community cares about, who are the leaders in your community. I would recommend looking for the opinion leaders. Who are the people that everybody listens to, who are well respected, who can help you influence some of the people that you need to influence. Another bullet is partner with faith-based organizations. One project that I was involved with when I was at Emory was the Prevention Research Center. And their focus was on nutrition and cancer prevention. Again, not necessarily substance use. But one of the things that they did, and they worked out of Dougherty County and all the city of Albany, which is very rural, they worked with faith-based organizations, both Black and white, because it's a southern county, and of course, faith-based organizations can be segregated. I think they're less so now than they used to be, but in a lot of rural communities, you have a Black church and you have a white church. They may both be Baptist, but as a preventionist, you really have to look at both. You want to identify what have been called cultural brokers. And these are people from the community, individuals from the community who can help you understand the community conditions, the politics, who the influencers within that community, and so on. Using social networks, figuring out who people talk to, where they go, and using those as hubs to begin to share information and to identify the needs of the community. When we talk about synthetic opiates and opioids, certainly a big part of it is empowering the residents and getting them to understand that they can make a difference. They may not see themselves as first responders, but certainly learning to use naloxone, assuring that it's available within the community. That's changing the perceptions, the social perceptions within that community. Online treatment has a lot of, the literature shows that has a lot of potential. And where there is good online access, that may be another alternative for you. The project that I worked with in Dougherty County, also looking at cultural brokers and influencers, we had the good fortune to be able to work with a physician, an internist in Albany. His name was Jim Hotz. And what I came to learn was that he was the inspiration for Doc Hollywood, the movie. I don't know how many of you are familiar with Doc Hollywood. Yeah, I see hands going up. Yeah, we were surprised, but he is a real person. He inspired the book, which then was the basis for the movie. He's still there, but he was able to do an amazing amount of work for us because he was so well respected, so well known. One of the things that he was able to do, because we were, as I mentioned, doing cancer prevention, one of the things we wanted to do was increase screening mammography for uninsured residents of Dougherty County. And, this is a very poor county with a lot of uninsured. He was able to convince the practitioners in Dougherty County to provide free services to the community. And that was a function of his level of influence with those individuals. Now, you won't always have a Jim Hotz in your community for sure, but you want to look at people like that who carry a lot of influence, who have the connections to enable you to get started in terms of your intervention, to help you be more familiar with how it works. What is the formal structure and what is the informal structure? What are the rules and who are the people who help, to get around the rules when they need to, or who can talk to the mayor or the local politician to help you. You'd be amazed at what you can do when that happens. So I know we're running out of time. I have some references there for you. I wanted to leave at least just a few moments to hear from you, any questions that you have, or thoughts, comments, your experiences working in rural communities. And we can actually unmute folks if you just want to talk, or you can type in the chat. So open it up.
Yes, this is Angelica Rodriguez. I just have a thought, and thank you for your presentation, Miss Irish Smith. So I work in thank you, ma'am. I work with a rural community, and I should confess that I never thought about reading about what you said about, I know a little bit more, but I'm just saying that kids or teenagers drink more in the rural communities than in the big cities. And I guess because the perception is that in the big cities, you have a lot of clubs of places where the kids can go. And you don't have many places in the small rural communities. And yes, it's where they drink more. And of course, it's because another things happening around. But just a thought. And then about the insurance, I was just thinking, oh my God, yeah, if I'm thinking in general because the insurance may be, I'm just saying, you get more expensive for people that lives in the rural communities, probably because you were mentioning that according to information here that that population, can die on early ages, because not they don't have access to the the like clinics or hospitals in the area. So those are perceptions that sometimes we have living in the big cities, like, oh yeah, everybody's has the same rights and the same support, but no, it's not true. Thank you.
Yeah, thank you. Anyone else? Any other thoughts?
Hi, Dr. Smith. I just want to say this is Antoinette Tone Silva Jose. I'm the Prevention Director for the Office of Substance Abuse Prevention. And I just want to say thank you for your presentation. I mean, it feels wonderful to have a lot of validations for what, what we see in the community, and you're putting it into the, academic research-based context of, these are things that we've been saying for a long time, and here, like you're saying, here's your proof. So I appreciate that validation coming from you through this presentation, but I also feel like it's you hit the nail on the head across the board for me, and I really appreciate your presentation of just things that is like that we've already been doing, or things that that make sense. And then I love your term community brokers. Was it community brokers?
Cultural brokers.
Cultural brokers. I'm like, oh, I love that. So I was just like, yes. I was sitting here just like really shaking my head, because it was truly a connection and aligned with everything that I was thinking about in regards to things you have to do. And then you also brought up some new important pieces to incorporate in there that, and I think it's of course, what's available to you, what resources you have, and maybe just some other things that could be available in the long run or down the road for us. And so things for us to look into. So I'm excited to explore some of these ideas. So thank you.
Oh, wonderful.
Dr. Smith, I have a quick comment. So I've noticed that within our community, and I suspect maybe in different communities, there's a disconnect between the prevention aspect of things and behavioral health services, and how I think that the community at large and the people involved are kind of confused about how to bridge those gaps in behavioral health services. So like, I think that we have a lot to offer as preventionists that really have an investment within our community. Do you have any, I don't know, this might be a longer conversation, but do you have any suggestions about how we could effectively kind of start to create those conversations in, shortening the gap in behavioral health services between the prevention world, social workers or preventionists, and the people that are actually doing direct services within our community? I guess that's the crux of my question.
Well, that's a good question. I'm glad you raised it. I think one of the things that's important when you're trying to bridge those kinds of divides, I'll call them, is that you have to first understand what your audience, the people that you want to connect with, what's important to them. You know, as preventionists, we have certain values that we come in the door with. If you're talking to someone in behavioral health or treatment, they're seeing the back end of that, and they're just kind of bailing water to keep everything from flooding out. And you're saying, why don't you just turn off the faucet? So I think you have to start with helping them to understand how prevention is going to alleviate some of the issues that they're most concerned about, which is the people coming through the door who need service. You know, how can prevention help reduce the number of people who come, or reduce kind of the urgency or the seriousness of what they see at their end? And again, you know, the cultural broker, find someone in behavioral health who can speak for you, who is influential enough. And you might have to spend some time with that individual, convincing them to get on your team. But the way to approach it is really look at it from their perspective. Listen to what they're most concerned about, and then make the case for how what you're offering can actually help them in the long run. Does that make sense to you?
Yeah, that makes sense. I'm interested in really trying to facilitate those conversations and get that going. So thank you so much.
Dr. Smith, we have a hand up from Lila Tonya. Do you want to go ahead and unmute with your question?
Yeah, I was wondering if there was.
I'm sorry, Lila, we can't hear you.
Can you hear me?
I hear
Okay.
you now.
Okay, my internet's a little rocky. I was wondering where we could access the data on veterans who have that have the lower mental health issues in rural communities than in cities. That was something I didn't know, and I'm kind of fascinated by why that variable might be there.
I don't remember which reference. I did give you a list of references
Okay.
on the slides at the end. Off the top of my head, I don't remember exactly where that came from, but I'll look it up for you and I'll send it. Yeah, that's a good question. I think we're probably a little bit out of time. I have 1:24.
You are correct. Our time has come to an end. In the of course, we want to keep everyone on schedule today. So I'd like to thank Dr. Iris Smith for spending the time with us today, sharing not only her perspective, but a lot of facts with us. And as she has so eloquently informed us, you do have your references in this slide deck, and you will all get a copy of this slide deck. In addition, we're going to do this presentation tomorrow as well with the PTTC, and we archive all of our presentations. So you'll have the opportunity to actually see this again if you would like to see the presentation again. But we just want to thank each and every one of you. Special thanks to Andrea Niehaus for inviting us to be a part of this event. And I just ask that as it goes with any federal program, it's not over until the paperwork's done. So I have a link in there for each and every one of you to please complete our evaluation so that we can continue to provide technical assistance and services like this within the region 6 of the PTTC.
Derek, we have a question about accessing that the URL. It asks for security code. Is that number 681072?
Oh, that's it, 681072. All you should have to do is from your telephone, if you have a URL reader, then click on that and it should take you straight there. If not, I put a link in the chat for you to click on. It should take you directly to the survey.
Perfect. Thank you so much. And thank you both for being here. Derek, for helping us coordinate. Dr. Smith, thank you so much for speaking with us today. Really appreciate your presentation. And thanks to everyone who's here. We also have a very brief survey when you log out of Zoom. Every topic from all of these meetings came to us through your feedback from previous meetings. So we want to hear from you what was valuable and useful for you and what would be valuable and useful for your work in August when we